our May 10th Project Echo Dementia. It is stellar looking outside. I wouldn't know. I've been inside all morning, but it looks lovely out there. Hopefully it is where you are also. So allow me to share my screen here. I am doing this from a different location and running from a different activity. And this laptop does not seem happy. We'll see how we do. There we go. All right, so I'm going to trust that that looks okay. It looks like you might see presenter view. Is that right? Do that.
Yes.
All right, how's that?
Now it's good, yeah.
All right, very good. So thank you for bearing with some technical glitches here. It wouldn't be a Friday without a few. And welcome to our May 10th Project Echo Dementia. I'm Chris Rhoads. I'm the neuropsychologist here at Memory and Brain Wellness, and will be your host and didactic presenter today. So welcome to you all. And we'll go through our usual agenda, some opening notes and reminders. If this is your first time here, we would love to get some information about you. So please feel free to put your contact information or your clinic in the chat. And then we will be talking about non-pharmacological treatment of MCI and dementia, followed by discussion. We do not have a case today, but we've got plenty to talk about. And worst case scenario, we may give you the gift of time and some of your afternoon back. So we'll see how we do. Some basic reminders, if you would be so kind as to rename yourself, who you are in your clinic. That helps us keep track of attendance and get to know our community a little bit better. Just a reminder also to please mute your microphone and practice saying your name when you unmute, which I'm still working on practicing that. If you're able to turn on your video, that's always great. We'd love to see your lovely faces, and again, helps us get to know each other a little bit better, but also understand that's not always possible. In the case that there's more than one person joining in your location, if you could put the names of everybody in the chat, that would also be super helpful. Some basic CME information. For any of our University of Washington related faculty, staff, or students, here's the number to send your email address to. It is a new registration number. We are in a new CME cycle, so that's 10085, and that should earn you credit for attendance. We'll put that back up at the end, also just as a reminder. For everyone else, it's our usual process, and Sammy will reach out if she needs additional information to make sure you get CME. Just a few other reminders of other series that may be helpful to you and your practice. The Traumatic Brain Injury Behavioral Health Echo, Addictions Echo, Telebehavioral Health Training Series, consultations for pain, the Telepain series, thorny issues that are often helpful to have some connections and input. Also the psychiatry grand rounds. I think I mentioned last time that the Neurology grand rounds is also a treasure trove of information. We'll put those links up there too. Some reminders, doing our best to protect PHI in any of our discussions. And also just a reminder too that all of our sessions are recorded and available on the website. There's no login or firewalls or any other barriers. All of the resources from those Echo sessions are also available. We're continuing to try to revise that to make it searchable and meaningful and easily accessible. There's a lot on there over the last 4.5 years, 4 years. And then, of course, we always appreciate your input from the post-session survey. I know it's one more thing to do, but it really has helped us refine the way we are constructing this series and building this community. So your input's super appreciated and welcome. We are accredited for CME, 1.25 credits. I don't have any disclosures. One of the nice things about being a neuropsychologist is that there are no pharmaceutical companies knocking on my door for any reason, really. None of our planning committee have any financial relationships either. And anytime there is one, there's a pretty strict mitigation process through the UW. Always appreciate your perspectives, though, too. If there's something that seems like it's maybe a little biased, please let me or Nancy or Sammy know, either directly or through the survey. That's another opportunity for that. I am reminded regularly that this is such a unique ECHO series and opportunity in that we are not just interdisciplinary, we are cross-institutional, and this really is a function of Project ECHO Dementia being a dementia action collaborative initiative. While it is administrated through the UW and the Department of Neurology, it is one that has representation from Swedish and Overlake, Virginia Mason Franciscan, and that's, I think, all too rare these days. So I really appreciate all of my team members here and just wonderful group with whom to collaborate. This is pretty up to date. I think there are some other stars that we could populate in the Seattle area. But since 2020 June, when we launched, we've connected with over 70 sites, almost closing in on 200 different providers around the state of Washington. And our efforts for this next academic and fiscal year will be to increase our connection with FQHCs. This program is designed to help rural and underserved or under-resourced populations, and FQHCs are such an important place where that happens. So we are engaging in some unique programs and efforts to try to pull in more community members. So we will look forward to welcoming them as they join. All right, this is me, and I will be talking about non-pharmacological treatment of MCI and dementia. The thing I will share, just as it's not really a disclosure, but clinically, I do two main things, at least in the world of neurodegenerative disorders. Half of my time is spent doing neuropsychological evaluations. We had a fantastic didactic by Dr. Tart-Zelvin on that. I'll refer you back to check that out. The part that I like more, and I think the people I interact with like more, is I also engage in both individual and group rehabilitation-oriented treatment of MCI and early-stage dementia. So as a matter of fact, I'm coming to you today, having just stepped out of our group treatment program. We are finishing up the first week of this 2-week program that I'll talk to you a little bit about later. So this is, what I consider to be my wheelhouse, and where neuropsychologists, psychologists, social worker, and other allied health professionals can add some value in addition to all of the other pharmacological interventions. So that's what I want to cover. And we'll talk about increased awareness of risk factors that are modifiable for cognitive impairment and dementia, and ways to reduce risk through improved management. We've heard about that in some of our earlier ECHO sessions as well. And then to talk about lifestyle interventions that have excellent evidence base and some pragmatic recommendations. And moreover, how do you actually work with people with memory loss and their families to enhance behavior change? So that's one of the big challenges, is people typically leave appointments with a good understanding of why exercise or diet or sleep is important, but how do you actually help them make meaningful and lasting changes in behavior, especially in the context of cognitive change or musculoskeletal or orthopedic issues that might undermine that. And then to talk about our resources and programs to improve quality of life. We had a fantastic didactic by my colleague and co-leader of this very group that we're just wrapped up with today around engagement and community resources and dementia-friendly work. And we'll just touch on that a little bit. It's such an integral part of what we do. So just as a reminder, and we've spent plenty of time on this in the past, this idea that for 7 or so million Americans, many, many more around the world, there is this abnormal trajectory of memory and other cognitive function over the lifespan that is impacted by this gradual accumulation of neuropathology. So this could be alpha-synuclein if we're talking about Lewy body, or amyloid beta or hyperphosphorylated tau, if we're talking about Alzheimer's disease, that begins around midlife, perhaps, with this escalating course and leading to different stages of either having a disease but being asymptomatic, so kind of a silent stage of a disease, versus mild changes in cognition or more profound changes that lead to functional loss and dependence, characterized by dementia. I think we would all agree that there's still no cure for something like Alzheimer's disease. I would also continue to argue that there are no readily or widely available disease-modifying treatments that are without significant risk or available to the population at large. But what we do know is that there are things that we can do through the lifespan that will suppress that neuropathological cascade and are associated with people staying in either the pre-symptomatic or very mild stages of cognitive change, and perhaps preventing progression to late stage. So either delaying onset of a syndrome that accompanies a disease, or preventing progression from maybe a mild stage to more moderate or late stage. And if you survey the literature, which we do regularly, these are the pieces that have the best evidence. So critical in terms of treating modifiable midlife and later life risk factors are cardiovascular health, heart health is brain health, helping people stay active and avoiding a sedentary lifestyle. Sitting is the new smoking. Treating and addressing sleep disturbances, making sure substance use is mild to moderate, or perhaps making some other changes if cognitive changes are present. Getting people moving physically around cardiovascular and other forms of exercise, keeping people's brains moving and applying more rehabilitation-oriented techniques to help compensate or scaffold cognitive changes. Some great data around diets that we'll talk about in a little bit. The importance of managing stress and distress, and the importance of staying engaged and connected. If you were to come to the Memory and Brain Wellness Center, these are the things you're going to hear about the most. And these are the things that we try to work on in conjunction with either deprescribing or appropriate prescribing of other medications, including monoclonal antibodies, but not limited to those. We probably have addressed this more than we've ever needed to, but I just want to remind you of the place of prevention and the idea that we're still hovering around 40% potentially modifiable risk for dementia, including improving early life educational opportunities. And as someone had pointed out previously, this is not the difference between obtaining a master's degree and a doctorate. If you'd only gone on and gotten those extra 2 to 3 years of education, your dementia risk would be reduced by 7%. These are for low and middle income countries where there are few, if any, years of formal education. So improving opportunities there. And those countries are accounting for a majority of cases of dementia worldwide. So the idea of building or enhancing cortical and cognitive reserve, but also better economic opportunities and healthcare literacy. So early life, certainly some importance there. We have talked about hearing loss in the past, and this is an area of both importance around screening for hearing loss that may masquerade as dementia or reducing later life risk at 8%. Another particular interest of mine is traumatic brain injury, as I'm also in the sport concussion world. And then are there heart and vascular risk factors? And of course, in later life, the idea of depression and isolation accounting for 8% combined. So again, modifiable risk of about 40%, potentially offsetting genetic risk depending on ApoE genotype. It's interesting data recently published around the 4-4 risk and what that may entail in terms of a mechanism for disease. But the things that we do, this epigenetic kind of phenomena, the things that we do having bearing on our later life cognitive function and risk for dementia. We have also talked about this in the past, multiple studies looking at midlife management of hypertension, and some controversy around this, particularly in the SPRINT MIND study. But overall, I think a proof of concept that intensive treatment, sorry, the slides have drifted up there a little bit. So that top there, which is hard to read, would be the aggressive treatment of blood pressure where systolic is less than 120, showing a decreased risk for MCI and different biomarker indications. And the reality of this is that is a very difficult thing to do and not necessarily always indicated either. But again, proof of concept that aggressive management of blood pressure leads to lower likelihood of MCI. And certainly, the real world implications of how many antihypertensives somebody would be on, or risk for falls, or other things, you have to consider all that. Appreciate that too. If we shift to exercise and physical activity, this is the, if people ask often, what's the one thing I could do to reduce my risk of developing dementia or MCI? And fortunately or unfortunately, the answer is cardiovascular exercise. There are over 90 meta-analyses in the last 5 years, including meta-analyses of meta-analyses now looking at this. All of these studies produce the highest quality and most consistent evidence of reducing risk. And there are likely multiple reasons for this. The paper in Hippocampus in 2021 outlines a couple of the key ones, including the idea of angiogenesis, the upregulation of things like brain-derived neurotrophic factor or acetylcholine, downregulation of cortisol. You get dendritic arborization with increased perfusion of the brain. So really nicely outlined, mechanisms why this may be the case. And the fact that there are certain subregions of the brain where neurogenesis is more likely to happen, including the hippocampus and mediofrontal cortex, versus other parts of the brain that don't seem to respond well to cardiovascular exercise. But there are also likely multiple domains or mechanisms by which other improvements happen. So the idea that we sleep better if we exercise, the idea that exercise is also one of the primary treatments for depression or anxiety, and that some cognitive constructs are enhanced more than others with exercise. So there's a greater benefit to frontally mediated abilities like processing speed, aspects of executive functioning, flexible thinking, more so than memory per se, or those frontally mediated components of memory like organizing and encoding information versus storage, or maybe some improvements in retrieval too. There is evidence, plenty of good evidence, that combining exercise with other non-pharmacological treatments like cognitive stimulation or dietary changes leads to a additive effect. And there's also great evidence that doing this as a healthy older adult has more of a benefit in either delaying or reducing risk of developing MCI, with less but still notable benefit if you already have MCI to reduce or delay progression to full-blown dementia, and then decent but not as great data for early stage dementia not progressing to mid or late. But there are treatment effects for each one of these, just decreasing over time and level of disease. Also, lots of interesting data that exercise done as a group or in a group format confers a greater benefit than doing it on your own. Not that there isn't benefit, but classes are great. They also serve as a great kind of accountability or structure to help with compliance. And finally, there was concern that, during the pandemic, this certainly got disrupted as people couldn't go to the YMCA or Zumba, but really lovely data suggesting home-based exercise programs are as effective or almost as effective than those that are done in a more structured external setting. So the evidence of this is such that it is one of the primary risk reduction guidelines from the World Health Organization. I'll be curious to see how this changes when it's updated in a few years. But right now, the strong recommendation that exercise should be recommended to adults with normal cognition to reduce the risk of cognitive decline. So in the group treatment program that we are running right now, critically important to have care partners engaging in exercise in tandem with their loved one with memory change to keep them cognitively healthy and doing the things that they need to do. You can recommend exercise to adults with MCI to reduce the risk of further cognitive decline. The evidence is kind of low for that, although take into consideration too that this was published in 2019. So the studies that they were looking at went up through about 2017. I think there was a top up in 2017. And I just mentioned in the last 5 years, we've got 90 meta-analyses. So that's hence, I'll be curious to see how this changes. The specific recommendations, all right, you can see those there. There is plenty of evidence now that would say you don't necessarily have to do the 20 to 30 minutes 5 times a week all in one shot, that as long as it's at least 10 minutes duration, you derive the same benefits. So the idea is of exercise, recess kind of approach, which is, again, it's great for people that don't like to do 20 or 30 minutes at a time. You can. The benefits are about the same. Similarly, about 45 minutes 4 times a week is about the same. But for people with musculoskeletal, orthopedic, or other issues, being able to break it up is a benefit. And the ability to kind of do different stations or different types of exercise. For those with poor mobility, the recommendations that you add in balance and fall prevention at least 3 days a week, muscle strengthening for major groups. So you can't just work your traps, you got to do the quads and other sit-stand muscles at least 2 days a week. And then if you can't do that, doing as much as you can. So those are the recommendations from that wonderful organization. One of the studies that I thought I'd dive into just a little bit, kind of demonstrating some of the impact of this. This was a really well done, well designed study looking at 2 groups of individuals, all with amyloid beta, but different levels of burden. So on the left here under A, in gray, these are individuals with amyloid beta 42 as detected by amyloid PET, but relatively low burden. Versus those in orange with higher burden, and what happens to their cognitive functioning, which is a composite cognitive score over time. And you see not a ton of change for those with low amyloid, which again, I think confirms that just because you have amyloid 42 doesn't mean you necessarily are going to develop the full syndrome that accompanies that. But for those with lots of amyloid, there's a significant decline in cognition. But that decline is mediated by greater engagement in physical activity, where there is very little decline. You also see in that same group increased cortical thickness in the inferior and middle temporal gyrus, the insula, parts of the precuneus, and the posterior central gyrus, singular gyrus, excuse me. So fitting with those areas of the brain that we know that are impacted both by Alzheimer's disease, but also movement, activity. So how do you do it? Again, people leave medical visits with lots of motivation and swayed by the evidence, and then you follow up with them in 3 to 6 months and nothing's changed. I used to include a cartoon that was a patient in a doctor's office, and the doctor says, what suits you better, exercising 1 hour a day or being dead 24 hours a day? And that stick doesn't drive people, right? I mean, the carrot does. And the knowing the benefits and soliciting people's motivation for why they want to exercise, but structure. If you look across the literature for behavioral interventions, it is there are 3 things that tend to predict whether or not somebody is going to adhere to an exercise regimen. One is that it is scheduled, right? So it's not just something they're going to do at some point in the day. A lot of things can get in the way. That resonates for me and maybe for some of you. That there is some accountability. So there's an exercise partner, there's somebody who's going to come knock on the door and say, hey, class starts in 10 minutes if you're in a senior living environment, or a friend who comes to pick you up to go for a walk, in the park. Physical therapists are fantastic for this. Personal trainers are fantastic for this. I'm a big fan of exercise diaries. And here's an example of one of the ones that I use. And there's lots of shared decision-making about this in terms of like, well, here's what the literature says. But here's where we've agreed you can start, and maybe it's only once a week for 5 minutes, but we're going to start there and we're going to capitalize on it. We're going to have to keep track. I also use this as a really nice way to help with just general orientation that they have to write in the month, the day of the year. They don't have to, but they choose to. And then you keep track of things like heart rate or distance or whatever it is that's important to you. Fitbits, other exercise trackers, pedometers, even, great external devices that capitalize on that whole idea that we change our behavior when we know we're being monitored. I don't always do it, but I certainly have. If I plan to follow up with somebody in a month to 3 months, I will call in about 2 to 3 weeks and just see how it's going. It takes 5 minutes, and sometimes it's enough just to, I haven't gotten started on that yet, but I'll start today. So that's not hard to do. Certainly helping people think about what they would like to do. The best exercise program is the one you're going to do. So if it's, I want to go to Zumba 5 times a week, great. If it's, I want to go, walk twice a week and swim once a week and bike 2 times a week, even better, fantastic. And then I'm a huge fan of motivational enhancement techniques and interviewing. This idea, the idea of like, on a scale of 1 to 10, how motivated are you to do this? I'm a 6. What would it take to get you to a 7 or an 8? Now we've talked about it. You know why I want you to exercise. Why do you want to exercise? Sometimes, again, the motivation may not be yours, but if you can help them elicit their own internal drivers, that's going to lead to change much more likely. So, importance of keeping the body moving and the heart pumping and that perfusion to the brain, absolutely. Also, a somewhat distant second in terms of quality of the evidence and magnitude of the treatment effect, but still present, is that of keeping the brain active. People always ask, should I be doing crossword puzzles or Lumosity or any of the other, millions of products now that are out there that offer different levels of promise for preserving cognitive function or enhancing. And you see something very similar to what you see with physical activity. And for, again, the forest plots, if you're not used to looking at them, the control groups for these tend to be things like, they vary with these studies, which is part of the methodology problems. But control groups might be something like listening to music or reading or like wellness education. Each of those are a little bit of an intervention. And then the actual intervention itself sometimes are things like learning cognitive rehabilitation strategies like chunking or spaced retrieval. Sometimes it's sitting down at a computer terminal and doing tasks of processing speed and trying to train those up. So there's heterogeneity here. But what you see is for older adults without cognitive impairment, there is a greater pooled treatment effect in terms of not developing or delaying the onset of cognitive problems. There's a little bit less of an effect for MCI, and then there's a little bit more variance or variability for early stage dementia. The treatment effect disappears by the time kind of late early stage, early mid stage. There doesn't seem to be much benefit there. And again, lots of variability in terms of what these actually mean. But if you go through those studies and look at the active ingredients and possible mechanisms of action, what you pull out, the common denominators are things like the importance of engaging in a variety of activities. So just doing one thing over and over again, not overly beneficial, at least for anything outside of that particular task. And the generalization of these, so do these actually mean you do better in your day-to-day life? Those outcomes usually aren't assessed. Sometimes are, but we'll get to that in a second. But the idea that you are doing things that challenge memory and language and visuospatial skills and executive functioning. Some of the better done studies, and this comes from the active trial, would indicate that tasks that challenge or train up processing speed have more of an impact than memory training or reasoning training. And that makes a little bit of sense in terms of processing speed as an underlying component that drives so many of our other cognitive functions, right? The more efficiently and quickly you can process information, that's going to confer benefits to other downstream functions like memory or executive functioning. The other active ingredient, and probably the most important one, is the idea of the appropriate level of difficulty. So it can't be too easy, but it can't be too hard. And one of the nice things about the prepackaged computerized programs is that they do this for you. So it's performance-based feedback around difficulty. So if you're doing really well, it'll increase the difficulty or decrease the amount of time that you have. But if you start to perform poorly, it'll back the difficulty back down. So it's constantly recalibrating the challenge level based on performance. Like cardiovascular exercise, those done in a group confer a slightly better or a slightly greater treatment effect versus those that are done on your own. Anything that involves new learning is important. And, things like reading, socializing, crosswords, we should be doing at least an hour a day of those. Many folks are already, doing that. But thinking about ways to enhance the challenge level of it. And here's some examples of prepackaged computerized brain games. However, really lovely study that was published in one of the New England journals looked at, what if you have people do these fancy computer games versus just have them do crossword puzzles? So these were 107 individuals with MCI due to Alzheimer's disease. They received 12 weeks of training and then some booster sessions that were kind of tapered over time, just to make sure they were continuing to participate. The thing I hear regularly about, and I'm not going to call out Nemosity in particular, but any of the computerized packages is they get boring really fast. And part of that is the plateauing of progress. Once you've kind of learned the task demands, people get kind of frustrated. But for this study, they stuck with it for 78 weeks. And at the end of that 78 weeks, you see a decline in cognitive functioning for the computerized games compared to not much of a decline for crosswords. Same thing for functional abilities and hippocampal atrophy. So greater for the computerized programs. Crosswords are interesting, right? I mean, there's a language component, there's an executive functioning component in that clues are not often kind of what they immediately appear. There's a spatial component. So there you go. Maybe we should all be doing crossword puzzles. Well, back to crosswords also. So this is another place where, it takes a little bit of discipline, or it takes a lot of discipline, but that idea of being able to self-calibrate difficulty level, right? I think about the New York Times crossword puzzle. Monday's the easiest, Saturday's the hardest, Sunday's the biggest, but it's a Thursday level of difficulty. So helping people with, maybe start on Mondays, and if Mondays are too easy, you go to Tuesdays, and then after a few weeks, you go to a Wednesday. If that's too hard, you back down to a Tuesday. So you can help people with that kind of calibrating. You don't need a computer program to do it, but it does take some insight and discipline. Shifting to a related but different topic of cognitive rehabilitation. And I think of these as in two general buckets. One is restitution, where you're trying to build back up or recreate or beef up your hardware in the brain, versus there are changes that are happening that require external compensatory strategies. So, you might have one approach with a mild traumatic brain injury with some functional impairment in the brain. You might have a very different approach for something that's going to be progressive and not likely to fully recover. There are internal versus external strategies, and they vary depending on which aspect of memory that we're interested in. So, for instance, people that have difficulties with encoding, you might help them chunk information so it's better packaged to facilitate encoding. Or you might help them, with elaboration of information, or do some errorless learning. And there's protocols for each of these. Storage treated differently. Spaced retrieval is one of my favorite kind of approaches for this, and it works great for very specific kind of concrete information. So I had a gentleman who wanted to remember the name of his physical therapist, and we worked on, he could remember it for about 5 seconds. So in about 4.5 seconds, I had him say it again. Then he could remember it for about 20 seconds at 19.5, right at the cusp of forgetting to say it again. So this kind of spacing out those episodes of retrieval and practice, but then also spacing out the practice sessions. So it's not just once every day, maybe 2 days in between now. Working with families on cues and prompts, giving the first phoneme or sound of a word to help facilitate retrieval versus saying it for them. So all sorts of great stuff through here. I'm also a huge fan of external systems and strategies. So I work with people on medication management systems, and I'm a believer of both the belt and suspenders, and maybe another belt if you need it. So not just a Mediset, but also an external reminder that is not a spouse. But there are clocks that are made for medications. Certainly, there's no shortage of apps or reminders on technology, and a tracking sheet, where you can write down the time you took this. And this is another opportunity to practice orientation where you got to write in the date, right? So it just helps reinforce those things too. Then you can couple this with some of those other strategies about these things always live in the same place. You always do it at the same time. You tie it to other activities. So some of those things that capitalize on procedural or habit memory. I don't count myself as super tech savvy, but it doesn't take too much to help someone, especially with some visuospatial problems, who would have a hard time finding their Google Maps on this home screen on the left, particularly if it's 9 o'clock at night and they're lost or disoriented. Unless you have practiced using this for many, many hours, it's not the go-to for most people with cognitive changes. But imagine that being a little different when you've helped them just streamline and simplify their phone, where all the essential things are right there. You still have all the other stuff; it's just not competing for your attention in the moment. So again, low tech kind of tech interventions here. This is not rocket science. Shifting a little bit to meditation. Oh, and I should have had a slide in here about how to implement these things. I am a huge believer and a proponent of working with our rehab-oriented colleagues. So speech and language pathologists are fantastic for these kinds of things. Occupational therapists are crafty wizards when it comes to some of these. Even had pretty good luck with some psychotherapists, particularly those that work with people with ADHD and have more of a behavioral approach. And then the importance of continued practice, the care partner who helps with carryover and implementation. You're actually translating this to how do you use this stuff in your home and in your world. So some pragmatic kind of recommendations there. When we shift to stress and managing stress, there are myriad ways to do this. Certainly, again, excellent evidence-based protocols with psychotherapists or counselors, exercise, prayer, social support, and meditation. And lots of interest in, particularly in mindfulness-based interventions over the last many, many years. And lots of interesting studies that look at fMRI or FDG PET to see kind of what's happening in the brain as we practice different types of meditation, and or how the brains of people who meditate look different than those who do not. One of the more interesting studies done in MCI lately was teaching people how to do mindfulness meditation. And there's a benefit to that in that it's a pretty low training need, pretty easy to teach people how to do it. Doesn't compete with any other spiritual or religious kind of preferences or backgrounds. Pretty straightforward, simple but not easy, I think is a good way to think about mindfulness meditation. And what they found for this group with MCI due to AD is that after I think this was 9 months of training and practice, they came back and looked at those that were in the intervention group, which was mindfulness meditation, versus the control group, which was relaxation. And they found increased cortical thickness in some of the areas that you would expect, including the anterior cingulate gyrus, the medial central cingulate gyrus, superior temporal lobe, and the insula. The anterior cingulate gyrus, to me, is super interesting in that, and I've both taught people how to and had my own practice of mindfulness meditation for a long time. And I think about it as attention training, right? Where you are choosing some aspect of the moment that you're paying attention to. Often you're breathing, could be sounds, could be motion, could be whatever you want. But you are paying attention to that. You are noticing when your mind drifts somewhere else, which is the natural activity of the mind, and you're and you are bringing it back to that thing that you were paying attention to without any judgment or criticism or chastising yourself. But you do that over and over and over and over again. And your anterior cingulate gyrus is one of the key structures that serves that freedom from distractibility, selective attention, shifting attention. And even in MCI, we see that that area responds. So there you go. Similarly, looking at FDG PET, very, very small sample size here, but 3 people with Alzheimer's disease, 5 with MCI due to Alzheimer's disease, similar kind of design of either 8 weeks of learning how to do mindfulness meditation or listening to music as a kind of relaxation control. But after practicing and some boosters, a year later, composite FDG PET scans show increased activation in both the anterior cingulate gyrus, prefrontal cortex, and decreased perfusion to the parietal lobes, which is important as that's a good indicator of kind of re-regulation of the default mode network. And we would expect decreases in parietal perfusion, which again helps people shift better from kind of idle state to task state. And they did better on all of these tests of cognition that we would associate some of those same structures, executive functioning, aspects of memory. And we could go through additional studies, including the benefits for care partners, but we'll leave it at that. And there are lots of great resources, especially for those of you who have patients and families who live in the Seattle area. There's lots of mindfulness resources, lots of great online ones now too for people who aren't in places where there's a group that meets. Talk a little bit about diet and dementia risk. I think we're all familiar with the MIND diet, which is a combination of the DASH and Mediterranean diets. In the original study, the landmark original study, which is now almost 10 years old, the idea that healthy older adults without cognitive impairment, about 923 of them, were followed for 4.5 years. And those that adhered to the MIND diet had a 53% reduction in incidence in Alzheimer's dementia, at least the clinical syndrome. They did not measure plaques and tangles, so that idea that may have still had the disease, but not the clinical manifestation. And there's been lots of interest in kind of what this might mean for maybe more of an intervention. If you have MCI or early stage disease, does it help kind of prevent later or greater cognitive changes? So stay tuned. There's a couple of big studies that are ongoing about that. Lots of questions about caffeine as a kind of an adjunct to this. And certainly caffeine's a central nervous system stimulant. And there is some evidence that between 300 to 500 milligrams of caffeine, which seems like a lot, although maybe not if you live in Seattle, but that midlife use is associated with a 65% reduction in dementia risk. Also, significant reduced risk for post-stroke dementia. And this study comes out of the UK Biobank. So this is close to 25,000 points or individuals. And it's all form caffeine, so it's not just coffee, it's also tea. So yeah, interesting. But again, probably more in the prevention than intervention kind of realm. Talk a little bit about sleep and dementia risk. Lots of interest in this, including the glymphatic system and the idea that sleep is an important stage to help clear amyloid beta and help the brain with other things like consolidation for memory. And likely multiple and complex pathways that are mediated through amyloid beta and tau release versus clearance. How that gets disrupted by hypoxia or sleep fragmentation. And in a very nice review that was published a couple of years ago now, looking at the major sleep disorders and those that are risk factors for neurological disorders, particularly Alzheimer's disease and Lewy body and frontotemporal dementia. These 4 are the key drivers. So REM behavior disorder, sleep apnea, longer time in bed, and habitual napping, which is maybe a proxy for daytime somnolence, but not snoring, not restless leg, and not sleep disordered breathing. So some things again more associated than others. How to help people with sleep. There's great evidence that people with MCI and early stage dementia benefit from cognitive behavioral therapy for insomnia or other CBT approaches. And a lot of these things I think we know around limiting screens for 30 to 45 minutes before bed, that idea stimulus control around the room itself being quiet, cool, and dark, activity restriction, so bedrooms for sleeping and sex only, controversial recommendations around avoiding pets in the bed, but getting people to do these things or helping them make these behavioral changes, that's a little trickier, especially when it's going to require involvement from a care partner, at least some help with carryover, but great data that these interventions are helpful in MCI and early stage dementia. This is a little hard to see. It's probably very small on your screen, but also a little review of some of the other kind of psychosocial non-pharmacological interventions for agitation in dementia. There are things that seem to exacerbate agitation, like light therapy, or do nothing, like therapeutic touch, or training family caregivers in some behavioral management strategies. That was a small, not really great study. Wasn't that well done. But some other things like communication skills and person-centered approach, music therapy, and programming pleasurable activities that are congruent with strengths and functional abilities. There's some treatment effect for those. And certainly, when we think about, we've talked a lot here around non-pharmacological interventions are the first line interventions for agitation and other neuropsychiatric symptoms in dementia. These take some training and they take some skill in applying them. It's not a cookbook necessarily, and requires some creativity, flexibility, adaptability, and distress tolerance as you put these in place and try to, how long do you work on it, right? That's always a question. But for the well-done studies, here's some of that evidence that drives that recommendation. The effect of psychological treatment versus treatment as usual on depression. I think for a long time, there was this myth that people with memory problems, MCI, early stage dementia cannot benefit from psychotherapy because of those memory problems. That is not the case. Certainly needs to be done a little differently, but people do respond quite well to cognitive behavioral and other interventions. Here you see the kind of overall treatment effect for that. And of course, when you think about combining non-pharmacological with pharmacological treatments and other treatments like exercise, kind of a triad approach, these tend to work as force multipliers for some of the other medications that might have limited efficacy. And here's a nice overview, busy kind of slide, but very, very large overview of non-pharmacological treatment of depression in dementia. And I want to disentangle this from the apathy and demotivational syndrome that can sometimes come with neurodegenerative disorders. This is either pre-existing comorbid or co-occurring major depressive disorder. And so individuals with mild to moderate dementia and or without MDD. And the things that had the most benefit were exercise combined with social interaction and cognitive stimulation. So that idea that it's a multimodal intervention, not far off from psychotherapy with reminiscence therapy and some environmental modifications. So you can see some of the other ones there that have some excellent evidence. And that leads me to the ultimate conclusion that each of these has an impact, right? I mean, there's data for each of these. It's a varying quality and a lot of heterogeneity and methodological differences between a lot of these studies. But increasing evidence that the more of these we do, the greater the impact. And the first, of course, to point this out was the finger study, which many of you are familiar with that, but a very large Finnish intervention that followed a huge number of people over 2 years. And the control group was kind of like a pep talk or motivational talk. But for the others that were in the intervention arm, there was specific nutritional guidance, recommendations and programming around exercise, keeping people's brains active, and then really dialing in blood pressure, cholesterol, all of the heart risk factors. The fascinating thing to me is, this is not a trivial intervention, and it's a long time. 88% of people stuck with it. And the findings were pretty striking that there is a overall improvement in global cognition, and then some differential improvements in different kinds of cognitive functioning. So executive functioning and processing speed, particularly for those that were over the age of 70, or the ones who had lower mini-mental status scores. Memory, not such a big change, so again, but an improvement, but not a huge difference between the control group. This has been replicated here, and now there's the worldwide finger kind of network that are looking at similar multimodal lifestyle interventions for dementia and comparing outcomes, protocols, active ingredients, which pieces have the most benefit. And two of the larger population studies coming out of the Chicago area, so the CHAP and the MAP studies, looked at having people engage in a healthy diet, moderate to physical activity, moderating alcohol intake. That should say no smoking. It did not ask them to start smoking, and then keeping their brains active. For individuals that adhered at a high level with 4 or 5 of those, you can see it was a 60% lower risk of developing MCI. And if you did 2 or 3, it's still a 40% lower risk. And again, not you have prevented the disease, but that ability to remain resilient in the face of a disease, or remain resilient and relatively stable despite the progression of a disease. Which leads us a little bit more locally to a wonderful study that we had the opportunity to partner with the Mayo Clinic on here at the University of Washington. We were the non-Mayo partner in this study, the Healthy Action to Benefit Independence in Thinking, or the HABIT study. And this was a 10-day, you could say brain camp, you could say boot camp. It was 5 days a week, 5 hours a day for 2 weeks. And all individuals needed to be at least amnestic MCI. We had a number that were multi-domain. The other sites were in Scottsdale, Jacksonville, and of course the Mayo Clinic proper in Rochester. But 270 plus dyads. You can see the mean age, more than half were male. And the interventions were, as you see here, so physical activity, which was designed as yoga just to promote accessibility and sure people could do it. There's a little meditation component in there too, but we can really talk about that. Brain fitness, which was having people sit down at a computer terminal and do cognitive training. Calendar training, which was the memory compensation, support group, and then wellness education. And the model was that we would do, per site, we would do 5 rounds of this, suppressing one of those aspects, so kind of like a knockout design, and then we'd do a 6-month booster session. And the goal was to look at which components, does this have any kind of an impact on progression or conversion from MCI to early stage dementia? And if it does, what program components are the most impactful? And you can see here that there's some differential effects of those programs. From participating in this and interacting both in follow-up at 6 months and then also continuing to see some of these individuals through my individual clinic, it's amazing how much some of these components stuck, and just really, again, capitalizing on procedural memory. A recent publication just indicated that the wellness education component actually has a greater treatment effect than was initially published or thought, especially for the younger folks. So from that, we designed a program, and this is the program that we are right in the middle of right now, that was more clinically oriented. And so I mentioned earlier, I see people both in a group and individual format. So for the ADAPT program, because every good program needs a good acronym. So this is the Applied Daily Activities to Promote Thinking. Right now, our current cohort, we have 7 dyads, and it is 6 sessions with the goal of increasing some space between the sessions to help with implementation and actually taking this out in your real life. And it consists of the following schedule. So people arrive, we do a 15-minute mindfulness meditation. We then do an hour physical activity program, which comes from Rebecca Logston's work here at the University of Washington. So this is stretching, strengthening, and a walking intervention. And then on the off days, we have people plan what they're going to do, and many are already exercising a half hour on the treadmill or a recumbent bike, so they're encouraged to keep doing that, but adding in these other components. We then do kind of calendar training, kind of just general wellness, but we use the calendar to help track plans and activities. There's a protocol for all that. We'll talk about it in a second. We then break the two groups into either the person with memory loss or the care partner. And then we come back together as a group and we close with a mindfulness meditation. So that's the program. The calendar system that we espouse and try to help people develop and implement is flexible, but it consists of a home system. And if you work with a speech and language pathologist to create a memory and orientation center, this is kind of what part of it looks like. So there's an orienting clock, there's your calendar, there's a whiteboard. The key is, being flexible about what these pieces look like. So the calendar, for instance, for some people, a month at a time is just too much information, or it causes anxiety of I'm worrying about this thing that's happening 3 weeks from now. So sometimes it's, it's a week at a time, it's a day at a time. So we work on being flexible with that. But this becomes the reference point for when the person with memory loss asks, what are we doing today? Or what time is that appointment again? The care partner has the ability to say, either answer that if that's okay for them, or to say, boy, I don't know, let's go look at the calendar. Boy, I don't know, let's go look at the calendar. Boy, I don't know, let's go look at the calendar. Reinforcing that procedural memory and habit learning of, I know where to go to look when I'm not sure about something. The other key parts of this are the personal system that goes out in the world with the care partner and the person with memory loss. They can both be electronic, they can both be paper and pencil. My experience is that people with increasing cognitive difficulties become increasingly frustrated with technology and prefer paper and pencil sometimes, although the opposite can be true. But the key is once a day, at least once a day, the care partner and person with memory loss sit down and make sure these things are all synchronized. Is what's on my calendar on your calendar? Are the pertinent things both on the home calendar? And it's a way to both orient to the day, to the activities, and then also kind of go through, oh, shoot, we didn't get that done. Let's move that to Thursday. So some couples will meet 3 times a day, some just twice, some just once. It really depends on the needs of the individuals. And this takes practice. So one of the most fun, and I'm glad I have a background in couples counseling, is where the home system's going to go, right? Because there's limited wall space and favorite artwork, and so that's a fun thing to help people negotiate. And then kind of moving into our last section here about the importance of programs and services. So getting people connected with support groups, educational events. You heard a lot about this already, but I think about all the wonderful programs that the Alzheimer's Association provides, different groups around town or the state provide around powerful tools for caregivers, strength for the journey, all those great things. The dementia-friendly work, which is really just such a wonderful example of a Dementia Action Collaborative and other partnership making changes in the communities in which people live. Momentia here in Seattle, Dementia Friends, intergenerational programs. One of my favorite pieces of art that comes from some of these here, this idea that this individual is still there and certainly contributing in great ways. Some photos of some of the events in the area. Again, you've heard plenty of this already. I want to remind you, I know you heard about it not long ago, but the Memory Hub, where I am sitting right now, is both where Echo comes from. Here's the photo of our proposed Echo room before this all launched. And then the ADAPT program, which I just mentioned, we're doing that right now. So some resources, I mentioned the risk reduction guidelines, those are there. A couple of really nice, pragmatic, actionable workbooks from the Alzheimer's Association. For individuals who are interested in mindfulness or connecting people with mindfulness, the Mindfulness Northwest is a great resource for some dementia, memory hub. And that's my contact info, which you already have from just Echo in general. And then we've got a bunch of references, and I think that's it. I think I will stop sharing there, maybe. And happy to open it up to discussion or questions. Also curious, in terms of your work with people with memory loss and families, what's worked for you? What do you find helpful? Sylvia.
Yes, so thank you for the overview. That's really helpful to kind of have the evidence that supports some of the things we say. My questions are mainly around exercise. I noticed there was, maybe a target heart rate. Is there any evidence that supports, how do you gauge it for, people of different ages, different, cardiovascular health? Like what, because it's a question I receive a lot. And I try to tell them, try to focus more on something that gets you to breathe a little heavier. And so I tell them between walking and sprinting for dear life, put yourself in the middle. But the heart rate question, I always never know what to say. I'm like, go to 100. I'm like, what if they have atrial fibrillation? What if their basic heart rate is like 55 because they're on the episode? What do you tell them then?
Yeah, good question. So the very first thing I tell them as a neuropsychologist is check with your primary care provider, cardiologist, whoever else before you start doing this. I usually ask, are there any cardiac, musculoskeletal, orthopedic, things we need to think about? Have you been told by a provider you shouldn't exercise or exert, and then always making sure that they're physically safe to do this. The studies themselves used the kind of the generic 220 minus age, 70 to 80% of that. That is the target heart rate. Of course, for somebody on a beta blocker or other medications, that's not going to be your metric. So it shifts to perceived exertion. And for that, my general encouragement is, you can talk, but you couldn't sing, right? That having like a fluent, full sentence conversation is going to be a little challenging. That's probably a good indicator. You're breaking a light sweat. That's probably a good indicator of you're in that right zone. So you can go on perceived exertion versus heart rate. But most of those studies and a bunch of the other ones that we didn't talk about it's 70 to 80% to the top or closer to the top end of the cardiovascular training zone. So 220 minus age being the top.
And then I have another question as to maybe it's kind of outside the scope of this talk, but I know most of these interventions are for MCI, really early stage. Once somebody gets into dementia, I still try to encourage some form of activity, both mental and physical. Are there any specific interventions that have been proven to be more effective as the disease progresses into the dementia stage? Because I think you kind of showed all the graphs and the studies that focus on dementia, and there might have been some that promoted or seemed a little more favorable. And I don't know if those indicate what kind of activities those were.
Yeah, it's tricky. The ones that have included people with more mid-stage or late-stage dementia, it's hard to come up with a good kind of outcome variable for that, right? Because it's hard to assess cognition or progression or functional change because by definition, they've already lost a fair amount of function. So a lot of those studies are things around more kind of neuropsychiatric symptoms and, what works for that. Programmed activities that are matched to function or previous interests. There is some data for that. So for somebody who was a mechanic, giving them like a bucket of bolts to sort or, those kinds of things. Or not light, but music, photo kind of reminiscence therapy approaches for mid-stage. So those kinds of activities, but exercise, I have yet to see a well done mid-stage exercise kind of intervention. If anybody knows one, I'd love to see it. But see, Karen Hayes also has a hand up.
Yeah, hi everybody. I'm the caregiver representative on the Echo Dementia, and I took several notes while you were talking, Chris. Thank you so much. But I'll make one comment and then ask one question at this point. Just wanted to say the very first thing that my husband and I did was go to Chris's ADAPT program when my husband was newly diagnosed and ready to stop being in denial about having MCI. I feel like we lost 2 or 3 years of being able to actively sort of get our handle on some of these wonderful things that Chris was talking about, just because we were both in denial and didn't understand really what was going on and so forth. So, but the ADAPT program really helped us, or helped me sort of focus what we were in for and things we could do that were positive. And this was in early 2019, and we maintained friendships with several of the couples who were in the program, which is now great because it's 2024 and several of the couples are now in the end stages of dementia. And my husband kind of went first and died first. And so I get to be a mentor with all of them, and we get to share experiences. And so it just brought together really nice. It was a supportive, informative, well-structured program that enabled us to get to know each other well enough that we all decided we wanted to stay in touch afterwards. So that's another benefit that I don't know if that's been measured in studies, but that was huge. And then my question, Chris, is about hearing aids. Now that a lot of people are coming to me and asking questions about dementia, or, I think my spouse has dementia, or what about my mom? And the hearing aids thing seems to be a bit of a stumbling block. I mean, now we've got a little bit better pricing and availability for them. But when they ask, I always say, how's their hearing? And do they have, oh yeah, they have hearing aids, but they won't wear them. Or I think the hearing's bad because they won't answer me, but maybe they're just confused and don't know what I'm saying. And so because of what I learned from Chris in the class and just learning more with my own husband and accessing the UW audiology folks, I really try to be a proponent. So my question is, what's a good little educational bite I can give them about why hearing aids are important? I just guess it's like, well, if they can hear what you're saying, there's less chance for confusion and less chance for them to be missing things. And maybe sometimes it's they didn't hear you. It's not that the dementia or the MCI is creating a processing issue, or is it actually that the hearing aids change the brain in a way that helps slow down the progress of dementia? I just want to be able to explain it well so I can advocate for it accurately.
Yeah, it's a good question. So if you think back to the Lancet piece, right, that's a midlife kind of prevention, that's 8%. So the idea of it being, preventative kind of intervention, I tend to get a fair amount of mileage with the budget analogy, right? That your brain has a certain budget of energy that it uses to do all the things it needs to do. And if you are spending a disproportionate amount of that budget trying to understand what someone's saying, or put all that together, you then have fewer resources to store information or retrieve information, right? So it's a really just trying, you're kind of freeing up some budget. I don't know what Barack would have to say there.
Yeah, the way I frame it is, it's a lot like, because we don't know this, we don't really know any of the science behind this is pretty sort of rudimentary. But I would say that in the same way that socialization helps people keep their brain active, that just like more input, and so I use the exercise analogy that if you are getting sensory input through hearing and you're getting sort of cognitive input through socialization, that's sort of working your brain and helping your brain to stay more active and stay more nimble in a way that if you are deprived of that, things sort of atrophy more.
Yeah, any other, kind of wisdom or clinical pearls about that? I'd love to hear them. Well, any other questions, comments? Oh, Trang Lee.
Hi, Chris. Great talk. Lots of information. Can you, I thought I missed the caffeine, or can you explain if caffeine has pros or cons? Or I wasn't sure on that slide. Thank
Yeah,
you.
so through that biobank study, somewhere between 300 to 500 milligrams of caffeine, as you know, measured in kind of retrospectively of what do you typically drink, what was your typical kind of level of intake, was protective around risk for later life dementia, dementia related to stroke, and overall stroke. So yeah, the assertion from that study would be that caffeine is neuroprotective to a degree.
Okay.
Barack, what would you add?
I wasn't going to add anything to that as much as I was going to just circle back to the exercise heart rate question as the primary care doctor that people will come in and sort of ask about. I will generally reassure people, you are not going to like exercise too hard and hurt yourself. And that, and so much of this is really like a psychological sort of benefit. And so people should be encouraged to exercise as much as feels good. And if it starts feeling bad, then stop. And but you really should, try to exercise as much as you can that you get enjoyment out of. And the odds that you're going to do any harm to your heart, regardless of what sort of medical condition you may or may not have, is so minor compared to just the benefit of just like getting out and trying to do what you can do. And so anytime anybody asks me about that, I just say, don't worry about it. Reassure them it's safe, it's good, you should do it.
It kind of reminds me too of the sleep piece where people get so hyper fixated on those details, right? I've got to be doing it just right. And if I don't, I'm not going to get the benefits. And, again, until we've got, outstanding data that would, provide a concrete answer around that, whatever you're going to do, the best exercise program is the one you're going to do.
And I would say the same thing with diet too. We should be eating healthy, and we should be eating good food, and we should be eating whole food, and we should be sort of having a rounded diet. But I think we can do harm in terms of people's quality of life by speaking with too much authority of sort of restricting this or restricting that, and that people should, to some extent follow their joy and eat what is tasty and live the best life they can.
Very good. Well, I think we are rapidly approaching time, if not already there. So I want to thank you all for attending. It's a little longer than anticipated, but there's so much to talk about. And I also want to highlight the fact that our next session on May 24th will be our own Dr. Mimi Pattison talking about palliative care and hospice for persons with dementia. So thank you, Mimi, for being ready for that. We will look forward to that. Sammy has put the link to the post-session survey in the chat. You'll probably also receive that. Happy to send out all the resources that we talked about today. And we'll see you next session, which is on the 24th.